I want to welcome everybody here officially today. My name is Amanda Falk. I use she, her pronouns, and I am a partner and chief clinical officer at the Dorm, which is an IOP and PHP treatment community for young adults located in both New York City and in Washington, D.C. Today, I am thrilled to be here discussing the overlap and differences between OCD ruminations and queer identity exploration in young adults. This is an area that is both clinically nuanced and deeply, deeply relevant to the communities that we serve. At the Dorm, we specialize in care for young adults, which we define as ages 18 to 30, a population that is both clinically complex and also increasingly diverse in identity. With over 50% of our clients identifying as LGBTQ+, delivering affirming care is central to our model. And that is why we are particularly grateful to welcome Dawn Anderson from Lindner Center of Hope to share her extensive knowledge into the best practices for differentiating sexual orientation OCD from identity exploration. Dawn Anderson is a staff therapist and supervisor at Lindner Center for Hope, where she serves as director of the Sexual Orientation and Gender Identity Treatment Team, chair of the Diversity, Equity, and Inclusion Council, and a member of the OCD, RODBT, and eating disorder teams. With over 15 years of clinical experience across outpatient, inpatient, and supervisory settings, including Cincinnati Children's Hospital and the Christ Hospital, Dawn specializes in treatment of trauma, anxiety, depression, and LGBTQ plus populations. So, without further ado, I'm going to turn this presentation over to Dawn.
Thank you very much, Amanda. I'm so excited to be here and to be able to celebrate Pride Month with this conversation. I hope that the people who are joining us here find it a valuable addition to their clinical experience, and you are able to walk away with some very accessible hands-on knowledge and tools to help you as you help your patients and guests navigate their world. So I'm going to share my slides. My pronouns are she and her. I would love it, especially if you have a question and you put it in the chat in the Q&A, that you include yours so that when I respond to you, I can respond to you respectfully. So again, we are going to be looking at OCD, specifically sexual orientation OCD and gender specific OCD versus authentic queer exploration. And our objectives for learning today include being able to tell the difference between those two things, understanding that from a biological perspective and the way that that is shaped for us and identity, and being able to get a head start a little bit, because we only have 45 minutes, a head start into how we can have some of those conversations with those types of patients, both those affected by OCD and who are wanting to explore their identity in your clinical practice. And as you got a tiny preview before, we are going to talk about sex. All kinds of interesting things. So important to know, you know your limits and you know what you need. So if you find something overwhelming or stressful, you can take a second and take good care of you. And in general, this topic is not meant to be triggering, so I hope that it is a safe space for you. But an important part of this discussion is being able to have discussions with terms that might be something we tend to avoid in clinical care. So we want to be able to talk about different kinds of sex, not just penis and vagina penetration, but being able to talk about the way that we are able to explore sexual behavior with our patients in a meaningful way. And we are going to talk about a different kind of sex, knowing the difference between gender, sexuality, and sexual behavior, because a lot of times those things, especially by the general public, get confused. And it's very important when you're talking about authentic exploration to be able to tell the difference for yourself so you can help your patients navigate that as well. And my favorite thing we're going to talk about that is super sexy is the brain. This handsome gentleman on the right of your slides is a super awesome human who developed the hand brain model. And Dr. Dan Siegel has a YouTube video that you can watch later if you find this really helpful in order to grasp this concept. I'm going to give it to you live because his model uses a lot of really specific anatomical terms. But in order to understand the brain and how OCD develops, I think that this way of understanding it is super helpful. So, when we think about the brain is two symmetrical halves. So, if you take your thumbs and wrap your fingers around them and put your fingers together, this represents a symmetrical model of the brain. So the first part of the brain that develops in utero is the brainstem, and it's in control of the things that we don't choose to do. So breathing, digestion, heart rate, fight, flight, freeze, and fawn reflex are things that keep us alive, live here. And then at the top of the brain, we have our cortex. Our cortex is in control of the things that we do choose to do. So at the very front, the part that is finishing development in the DORMS population, the prefrontal cortex, the ability to see the future, make critical decisions, and plan ahead. And then more at the top of the brain, we have our elective functions like being able to choose to look at things, to smell things, etc. And in the back of the brain, we have memory. And we're going to come back to this part in just a second after I explain the limbic system. So, in the middle of the brain, you have this wonderful part of it that has a couple components that's job combined is to keep you safe. Your limbic system takes in the information that you see, smell, taste, hear, and feel and decides based on genetics and life experience if it's safe or not. So, for example, if you are a professional lifeguard, your reaction to water is going to be different than if you've had a near drowning experience. On the genetic side, if you are someone who tends to come from a family that is high anxiety, you're going to have a more reactive limbic system than someone who comes from a less reactive or under responding family. In the way that our other mental health conditions can affect it, trauma makes your limbic system more reactive as well. So your brain takes in that information, all that data that you're seeing, smelling, tasting, hearing, feeling, brings it into the limbic system and says, is it safe or not? So sometimes we like to think of this as like the fire alarm of the brain or like the bouncer of the brain, if you think of like going into a club. And so that system, if it says, well, yeah, okay, I think it's safe. Sends it up to the cortex, and this is everyday life. We go on with our business. We are able to process that information, interact with it, make decisions. If our brain says, I don't know about that, we go into a state of vigilance where our senses focus and sharpen, paying attention. So you might notice or feel familiar to this if you've ever walked down a dark alleyway, or for those of you who were affected by the storms last night, when like the thunder and lightning and heavy rain is happening, when all the alarms start going off, we have that feeling of pay attention, pay attention. And then if our brain says, absolutely not. So if you joined into this conference call and there's like a real life-sized tiger sitting next to me or a tarantula crawling on me, then your brain would say, absolutely no thanks, just like mine would. And it sends it down to the brainstem, and we have one of those fight, flight, or freeze or fawn reactions, where when that's happening, your brain isn't actually moving, but it's the movement shows you how much power is being deferred out of the thinking brain down into the surviving brain. And this is really important because OCD is a faulty system that affects a lot of the interaction in that safety system. So if you've ever been in a place, hopefully not your own home, but possibly, depending on how you live your life, where the fire alarm batteries are going bad and they're chirping, and you're like, "Ooh, what was that?" And then you need to change those batteries so that they don't keep doing that. But if you have a faulty fire alarm and it goes off, you question, is there really a fire? What's happening? Because we don't know that it's a drill. And so, what happens in the brain for someone who has OCD is that the stress system is going off when there is no present danger. And so, what ends up happening, because we're intelligent creatures, is that their brain says, well, clearly, I feel like something is wrong. So, usually, people with OCD start out by trying to go through some of the common things like, I'm looking around. Are other people feeling this way? No one else seems to be hearing this, just me. Sometimes they seek reassurance from other people. I don't feel well. What's going on? Because that fight or flight system raises our heart rate, quickens our breathing, stops digestion. A lot of things are happening all at once because the brainstem is connected to every single internal organ in your body. So it has that reaction really quickly. And when we talk about the progression of OCD, again, because we're intelligent creatures, a lot of times OCD tends to follow specific themes like contamination or religious or spiritual concerns. Did I do something morally unokay? Or harm? Is something bad happening to me or to someone else? Or taboo topics. Am I doing something or is something happening to me that goes against my values or that I think is wrong? And when we talk about those consistent themes, a lot of them have to do with trying to make meaning of this sense of danger. Because in the same way, if you are having that alarm, that fire alarm going off, and you're like, what is happening? Clearly there's danger. I don't see any smoke. I don't smell anything, but it keeps happening. What is wrong? And then what ends up being the next step in developing OCD is that people develop rituals or compulsions to try to get the distress to stop. So if I think, is there something unclean on me? I'm going to go wash my hands and try to get rid of this. Or did I make a mistake? I'm going to say a couple of prayers and hope that I'll be okay. And when it comes down to what we're talking about today, when we talk about taboo topics, am I am I attracted to that? Do I am I gay? Or in not necessarily sexual orientation, but a similar umbrella when we talk about people who have pedophilic or POCD, where they're concerned about being attracted to children. Sometimes there's also content related to like incest. Do I find my own kids or my own siblings attractive? It's not because they do, it's because the fear of that being the thing that's causing the distress for them is where their brain went. And so they start doing checking behavior to like, am I aroused right now? Ew, I don't like this. I'm gonna avoid sexual behavior altogether, or I'm gonna really quickly count my fingertips, or I'm going to like clean my hands or my phone so that I can get rid of this feeling of not okay. And so what ends up happening is that when that distress is relieved through the compulsion, one side, because a lot of times compulsions do have a sense of like they tend to be linked sometimes to things we would use for regulating skills. So they release a little bit of endorphin to regulate us. But on the other side, because this faulty fire alarm doesn't go off forever, so what ends up happening is the fire alarm eventually stops going off and that they have a sense of relief. So the brain throws itself a dopamine party, a reward party that's like, you're welcome, I kept you safe. And what ends up then being the outcome is that that cycle is reinforced. So then it keeps happening more and more and more. And when we talk about the parts of memory that I wanted to come back to before we move on to our next point is we have three states of memory in the brain. We have short-term memory, which is what I know right now. So you might remember that my name is Dawn. Long-term memory, which is what I know when I think about it. So like your address of your childhood home, or who the first president was if you're in the United States, or what your parents' phone numbers are. And then at the bottom of the brain, deep in the brain, we have state memory. State memory is things that we know how to do without thinking about it. So when all of you got dressed this morning, or brushed your teeth, or walked, talked, ate food, you had to learn how to do that at one point. But because you've done it over and over and over and over and over again, it's now become state memory. Your body knows how to do it without thinking about it. And so whenever we're teaching our patients coping skills or regulating skills or crisis response plans, the reason they have to practice them until they can really use them when they need them, they have to bring them down to state memory, because the more distressed you are, the less your thinking brain is online. And this is what causes a lot of people in the OCD world to have a really hard time, because their level of distress is really high, because it's linked to these things that are high level distress. And it's really hard for them to think clearly. So when we have that kind of in mind as some of our underlying pieces here, cooperate with me, PowerPoint. Looking at this a little bit more visually, I talked about this. We talk about some of these subclusters for OCD. So we have contamination concerns, things about germs, dirt, cleaning products, environmental contaminants, symmetry and arranging, needing things to be just right, tapping or touching things in a certain way, needing to be in a certain order. Then we look at like the taboo thoughts. So we were talking about sexuality, gender, attraction to things, being associated with things that people find that don't go with their values. And then there can be some tangent related disorders to OCD that can include hoarding or body dysmorphic disorder, where someone's feeling of their appearance doesn't match the way that others see them. So when we talk again a little bit more about understanding OCD, OCD is a cycle of those distressing thoughts, the feeling of wanting to get relief, the act of trying to get the relief through a behavior, the momentary absence of distress that then has the reward circuit. And then this starts over again, because that faulty fire alarm is a part of the brain. And this is something we spend a lot of time. One of the most important parts of OCD treatment is psychoeducation, because it's super important for patients to know that the content of their OCD is mostly irrelevant. So when we talk about, not irrelevant like it doesn't matter to me, irrelevant meaning that it often changes over time. So saying that you have contamination OCD doesn't mean that you're better or worse. Usually, as you treat one type of OCD, it tends to populate as a different subtype, because the brain has so much experience and data to say, oh, I can handle this where I thought I couldn't. Then it populates as a different one. So oftentimes you'll have patients who start with lower levels of OCD, like when we talk about lower level being less taboo to get treatment for. So it's a lot easier to show up in a clinical practice in order to get treatment for concerns about contamination with germs than it is to come in and say, hey, I'm really terrified that I might be gay. I'm really terrified that I might be attracted to children. And so it's important to know that it's common for these things to shift, and we want patients to know this so that they don't feel a sense of shame or failure when their OCD may transition to a different subtype. Just some kind of quick catch-up facts. Williams and Wetterneck are two of the bigger researchers in the SO-OCD, sexual orientation OCD, that was formerly called homosexual OCD. And as we've evolved as a species and been more intentional with language as well as appropriate care, we've talked about the value in understanding that not just people who are heterosexual or straight worry about being gay. Sometimes people who are gay worry about being straight because OCD is not discriminant. And about 1 in 50 have a chance of having OCD. It's really important to know how prevalent it is, and that's part of the reason why I was wanting to make sure that I offered this discussion, because it's one of the more commonly misdiagnosed conditions, even by clinicians who should have that level of training. So when they've done DSM level research in preparation for new additions, they've given assessments to the providers who are working on that. And there was a shockingly significant amount of people who misdiagnosed this, which was, again, the underlying drive of this talk, because we want people to have access to the care that is the care they need. So if someone is queer, we want them to be able to have healthy, productive discussions about healthy sex lives, healthy relationships, making sure that if someone is transgender, they get the appropriate care they need. And if someone has OCD, we want them to be able to access exposure and response prevention, the gold standard of OCD treatment. We want them to be able to get access to medications to help soften the volume of that alarm system in the brain. And so, a part of making sure that excellent clinical care standard exists is good education. So, thank you for showing up for this, getting that started for you. Flipping over to the other side, some basic terms, just again, making sure we're all speaking the same language. And I think this is super important. Recognize that also in your community, especially outside of the United States, you may use different terms. And one of the things that I absolutely cherish about other languages is that sometimes there are concepts that we don't really have. So when we talk about, if you've ever heard of like the 2S on the end of the LGBTQIA 2S, in indigenous cultures, they have the concept of a spirit when we think about our sense of personhood inside of us. And some people have a two-spirited identity where they have the concept that there's more than one spirit inside of their physical being. And that isn't something that really translates super well into casual English. Gender describes our sense of who I am as a person in terms of my sense of masculinity, femininity, intersex, or non-binary. So like when I think about, am I on like a spectrum of how I present to the world? Where does that show up? Sexuality, what am I attracted to? What kinds of things do I find romantically appealing? What kinds of bodies do I find that I want to engage with? And that links over into sexual behavior. Just because someone has a sexuality doesn't mean that they want the same amount, type, or frequency of sexual behavior. So, for example, I can be I can have a gender of male or demi-male if I feel like that is a gradient part of it. I can have the sexuality of heterosexual or straight, and that doesn't mean that I want the same kind of sexual behavior as another male who identifies as straight. There are a lot of ways to have good conversation with people, and these are some of my favorite tools. They again are linked for you in the references. There are a ton of them, and I would be shocked if the people in this chat hadn't seen the exploratory unicorn. It's one of the most popular ones, which is why I didn't put it in my slides, because I wanted to present some things to you that I use regularly. Sorry about touching my mic. That I use regularly, because when we talk about things on a span of a spectrum, sometimes that makes more sense to people. And when someone falls where they feel like they don't quite fit, that can make it feel a little bit more invalidating for them, as well as sometimes we just like visually other things. So thinking about it as a galaxy concept where we're able to kind of think about, where do I fall here in this more expansive open space, for me just makes more sense. So some of the ways that we talk about gender is I say, tell me a little bit about what that word means to you. Tell me a little bit more about what was modeled for you growing up. Tell me When you think about masculinity, when you think about femininity, when you think about a sense of who you are, what does that mean for you? And sometimes it helps people when we give them examples or when we talk about, like the difference of stereotypical to your culture that you might, or to the culture of the person that you're working with. What does stereotypical femininity or masculinity look like? Same thing with sexuality. When we talk about the difference between romantic attraction, who do I feel pulled to? What kinds of person do I want to be in a relationship? Do I want to be in a relationship with more than one person? Do I want to be in a relationship at all? Just because I want sexual behavior doesn't mean that I necessarily want a relationship. And then when we talk about sexual orientation, I might ask them things like, let's talk about what kinds of sexual behavior you want to receive. Let's talk about what kinds of sexual behavior you might want to participate in. Do you want to interact with a penis? Do you want to interact with a vagina? Do you want to interact with someone who is intersex, who may have both or neither? Is it important for you to engage more with your mouth? Do you have certain sensory things that you enjoy in terms of you are someone who enjoys taste or sound or visual? On the bottom down here, which I know you can't see because it's too small, but there is no way to get all of this in here in a helpful way. So think of it as a sampler platter. You can get the full size plate on later on the internet and then my references. This is a kink map. Kinks are something that, as long as you are engaging in consensual, safe behavior, are a healthy part of sexuality. When we talk about, like, even on this side, more common things that we find enjoyable, the difference when we talk about a fantasy versus an OCD distressing thought is the enjoyment of. Fantasies sometimes can bring us a sense of edgy anticipation. That is not the same feeling as distress or fear that would come up for someone with OCD. And so when we're doing healthy exploration with someone, when we're looking at how do I help an adolescent or a young adult explore what sexuality or sexual behavior might look like, a lot of times we have to keep in mind that there isn't a lot of thorough or helpful discussion provided to the average person when it comes to sex education. Most public school systems teach abstinence only, and there is a lot of discussion about venereal disease, but not a lot of discussion about their own anatomy. And so it's helpful and important to get a baseline, make sure that you're presenting yourself in a way that opens that discussion, models that humility, and recognizing, I also did not get an education in my primary like schooling experience. It wasn't until college that we were having discussions or even looking at real human bodies when we talked about the differences in anatomy, understanding that not all penises look the same, not all vaginas look the same, not all like areolas look the same. So when we talk about those differences and understanding what's normal, what's not normal, where are these parts of the body, it's something that's a really helpful discussion to be having where we're saying, hey, is this something that you want to be exploring or talking about? And oftentimes it's hard on the clinical side to know how to have this conversation. And my encouragement starts with that informed consent. I'm saying, hey, like, how would you like me to put down your gender and sexuality for charting purposes? What are your pronouns? How would you like me to put this in here? Is this something that you want me to be using or something that you want to be a part of your record? Is this something that like supported by your legal documents, or do you need your notes to be billed differently? Because if your insurance and your notes don't have the same information on them, sometimes insurance won't cover them. So we have that discussion. And then that can lead into, is that something that you want us to spend some time on? Do you want us to spend some time talking about sexual behavior? Do you want us to spend time talking about your sexuality? And it gives you that opportunity because most of the time I find that people will say, yes, I would. Not right now. I want to wait till we know each other better, but I do want to talk about that. And then I know, okay, when we have more rapport, when you trust me more, we can talk about this. Coming into the intersectionality now that we've gotten our little definitions of them both. So, sexual orientation OCD and authentic exploration, part of like the main point that I wanted us to get out of our discussion is that telling them apart and making sure that we're on the right page with someone who has OCD versus someone who wants and needs to do authentic exploration is knowing how to tell the difference between the two. So when we talk about it's totally normal for people to be unsure. We oftentimes like start questioning things as we are exposed to them and learn them. When we think about some of us have a clear image in our mind when we think back to early childhood and finding someone cute, finding ourselves having a crush on someone, finding that we were having awakenings of sexual development as we progress through puberty. For other people, especially people who fall on the queer spectrum, that can be confusing or it can be difficult because there can be messages about things being unacceptable. There can be a lack of accessible role models where they feel like something is happening, but they don't see it anywhere else in their world. And so it feels maybe like it's not the way they should be feeling. Sometimes for people who are asexual or who are non-binary, they feel like they have a difficult time with knowing how, like, is I don't feel what I think other people are feeling. This doesn't feel quite right. And that can, again, overlap with this not quite right feeling that is pretty classic of OCD. So when we talk about gender and sexuality identity, there's a lot of questions that come up. And so we want to be asking really thorough questions. And one of the most important elements, like I touched on before, is the feeling of high levels of distress. And so when we figure out people who are afraid to be gay, we want to dig into what goes into that fear. What's that part of it? A part of a lot of us wanting to be affirming providers is that sometimes when someone says, "Hey, I think I'm gay," we have the temptation to go like, "Hell yeah, that's awesome. I love that for you." And sometimes that feeling of like, I'm getting this is being reinforced, this is going positively, can be harmful if that person has OCD and they're like, "Oh, I should feel this way." So we want to make sure that we're doing some clear and non-judgmental questioning around that. A lot of times, people who do have OCD will tend to have a really strong fixation on wanting certainty. I would say that this can sometimes happen in young adults as well because there's such a strong feeling of like, I want to know, I want to feel like I've got this, I want to know like what I want. And that's not a bad thing to want to that clarity in like the authentic space. Also, though, knowing that when we have a good conversation about how oftentimes what we find attractive and what kind of behaviors we want to engage in do change over time, we don't really have that rigid certainty in authentic exploration that OCD tends to really get stuck on. And a lot of times you'll see a lot of internalized marginalization, which is a different way of saying sometimes people who either have been experiencing an ostracization in their community or who have sexual orientation OCD will make disparaging remarks. Again, we have to recognize that there is valid reasons, especially in the United States, to have fear around being open with certain parts of your identity. And sometimes that can cause them to push away from that community. Bigger idea, though, when we think about that sense of fear, a lot of times people with OCD, there's this element of non-logic where they will say things like, I don't have a problem with gay people, I just don't want to be gay. And that's giving you some clues around maybe this is something that isn't as straightforward as I thought. When we talk about sexual orientation, OCD, there's a lot of disruption in the sex life. There's a lot of intense distress that can happen with something that we call intrusive thoughts, which is a pretty strong symptom in OCD in general. We have lots of intrusive thoughts as human beings with or without OCD every day. So if while you're on this call, you have the thought, what am I going to do this weekend? I wonder where Dawn lives. What am I going to have for dinner? Those are all intrusive thoughts because they're happening non-electively. You didn't choose to have that thought. However, in OCD, some of those thoughts contain elements of things that activate that fear response for them. So for me, if somebody said to me, Dawn, what if you had dog poop on your shoe right now? I don't have contamination OCD, and so my reaction would be, ew, I hope not. But if I do have contamination OCD, it would evoke in me a very strong stress response. What would be coming out is, do I? Oh my gosh, I need to check right now. And it's not like that level of I'm in control, it's strong distress. And so sometimes people who have concerns about being attracted to children, being attracted to family members, being gay, will have intrusive thoughts of I'm kissing my partner and I have this image pop in my mind of a young child, and it's very distressing for them. They oftentimes will immediately stop and avoid sexual behavior because they don't want it to happen again, which can cause us to fall out of healthy patterns with our partner, can cause conflict in that relationship, things again that cause difficulty in their lives more than just the symptoms themselves. A lot of times, again, because it happens in sexual behavior, that those intrusive thoughts have such an incredibly strong distress response that it can cause them to feel reduced arousal overall. Also, super important for people to know, quite a few of the medications that we use for regulating mood can have that as a side effect. And a lot of people don't know that, so they think there's just something wrong with them. And so it's important if we know those things when they're bringing them up. Have you talked about that with your med provider? Because it's a possibility that it's a side effect of the medication as well. And also, they can develop erectile dysfunction, vaginismus, which is a very painful condition that causes contracting on the inside of the vaginal walls that can make inserting tampons, inserting fingers, etc., very difficult and painful. When we look at also incredibly high risk and concerning um, parts about why people avoid seeking help, we're mandated reporters. So if someone comes to me and says, Dawn, I'm terrified that I'm going to sexually assault my child. Dawn, I am so scared that I keep having these thoughts about what if I'm attracted to kids. It happens that people do get reported for those kinds of things. And so it's super important for us to know that the difference between the fear of and the likelihood of that behavior. And again, a lot of times we see people who won't take care of their kids, who avoid gay people because they think that they may increase the likelihood of them being gay. They're checking their body. So when we talk about this word down here, you may have heard before, a groinal response. As a species, anytime we talk about sex, there is going to be non-elective response from the body. So even just in this presentation, if you go, and check your body, you may notice that your body is having a reaction to it, not because you find this sexually arousing, but anytime sex is mentioned at all, there's a part of our brain linked to survival that goes, huh? Did you need me? And that's a groinal response. But people who have OCD will check for those, and it causes difficulty because they confuse that for attraction. In terms of assessment, there are a couple of tools that are super helpful to use, very clear. The Yale-Brown Obsessive Compulsive Scale is the most baseline measure for assessing OCD. However, it's not the most helpful when it comes to sexual orientation OCD because there are only a very small handful of questions that ask about it, And so when we use this as a general screener in order to get like some of the topics that have been affecting people, this is like kind of a broad net. And then we bring that into the SORT assessment, sexual orientation, obsessive and reaction test. The SORT assessment, which is over on the left side, is the set of 12 questions that really digs into the sexual orientation part of OCD. So it's asking questions that are more specifically related to the fear underneath those things. I need to know for sure that I'm straight. I check myself to see if I'm sexually aroused around other people. I worry that I'll lose control and become LGBTQ. This assessment is scored 0 to 4, and any score above a 10 warrants further assessment for sexual orientation based OCD. And then I won't go through this chart on the right just for time, but it's a differential diagnosis chart from the developers of the SORT assessment. Again, just reiterating these same concepts we've been talking about when we look at the difference between I'm worried that I might be rejected from my community versus I'm worried because I don't want this to be happening as one example of that fear space. So when we look at our basic treatment objectives here, if we start on this side, most importantly, we want to do some checking in on what's their priority. So what did they come to you for? What is the thing that they want to be working on? If we're working with someone who we do find out has sexual orientation OCD, a lot of times the level of distress for them can be really high. So if appropriate, we want to make sure that there's safety planning for suicidal ideation. We want to check in and make sure that we're having good communication with their medication provider and their medical team, especially and when we talk about people who may have already engaged in some medical services related to transition. We want to make sure we're in good communication with those providers. We want to work on developing a treatment plan. And again, exposure and response prevention is the gold standard of treatment that is a whole presentation all by itself. And no matter whether they have sexual orientation OCD or they want to work on their authentic exploration, working to build confidence in their identity is a very helpful and valuable moment in that. I wish I had time to go through our clinical case presentations. I do want to save time for questions. So I am going to stop sharing so we have a chance to do that.
Thank you so much, Dawn. A lot of there's definitely a lot of chatter in the Q&A and in the chat. So I am going to get right to it so that we can try to get to as many questions as we possibly can. I don't know that we'll be able to get to all, but we'll try our best here. Okay, we had a question come in asking if you can differentiate the anxiety slash distress that comes from OCD around gender slash sexual orientation and the distress and anxiety that comes from holding the oppression and judgment that someone anticipates feeling when coming out when questioning their gender and or sexual orientation.
Great question.
It's a
Thank
good
you.
question. Yeah.
Um, I would say again, that's where I always start with, hey, what is like your experience in having these conversations? I try to get a good foundation around their definitions of those words, how they have experienced having conversation about that, how those things were modeled, what safety has been like. So if someone's coming in and they're saying, I think that I'm trans, my parents are very against that. Like I'm worried that if I, come out as gay or I come out as trans, that I may be sent to, conversion therapy or that I won't be able to stay in my home. Those are very different conversations than when we think about, you know, general who am I? So someone who does live in a safe space and environment. And one of the things when we talk about your core question, what I thought I heard the core question of that is how do I tell the difference in the distress? That would be looking at, is the fear about the other people and their judgment, or is the fear related to me? So someone who has sexual orientation OCD is afraid that they are gay. They are not, they typically don't have strong feelings about other people being gay. They typically don't have like, so the same thing, I'm worried I'm trans. I'm worried, I think I feel like I'm a man, but I'm worried that I'm really a woman. Those things come down to that element of distress around that's not wanting to be true for them. In the same way that people who have other forms of OCD, if they have, for example, the classic, contamination, I don't want to have germs. If someone else was like, doing the thing that they're afraid of, for example, like picking up, this fell on the floor and um, they don't want to get the germs from the floor. They don't have a problem with me doing it, except that they don't want me to touch them because the fear is self-directed versus I'm afraid of how other people will feel about this. Because factually, we know that depending on what's happening in the political climate, it can make things more difficult for them. And so some level of stress or fear or contemplation around that is an appropriate emotion to have.
Yeah, thank you. We have another person who is asking if if reassurance seeking is a compulsion, how do I avoid accidentally reinforcing it just by validating my client's feelings in a normal and supportive way?
Great questions. Man, I love this. Okay, so when it comes down to working on reassurance seeking, we always try to start with figuring out what is it that we are specifically trying to target in reassurance. And this is where actually in one of the cases that I brought, um, sometimes people who have OCD will not have that appropriately diagnosed. And because we want to be affirming, they will progress through getting gender affirming care and then get to the kind of pinnacle or at some point in their care and go, this doesn't feel right. This doesn't feel like me. And so when we talk about like being affirming, it's important to know, like, just like when you're thinking through someone getting into a new relationship, do I affirm in general? Do I encourage in general? Am I using my judgment of like, what am I encouraging or affirming about them being in a new relationship? Is it them having the confidence to ask someone out or to be willing to start dating after working on that in clinical treatment? Or when I'm talking about the reassurance specifically, a lot of times reassurance will be things like they'll ask, is this is this aroused? Do I like this? Is this is does this if I stand like this, do I look gay? And so when we know what their specific triggers are, what their specific fear points are, my response is what would be what we call a non-engagement response, which sometimes is just bringing it back to them as a question, like, what do you think I'm going to say to you about that? Or what, like, say more about what you're worried about instead of giving them the quick yes or no that they're looking for.
Thank you. We actually had a couple people ask a similar question. I'm going to try to consolidate it into one. This is around assessment. And is there a similar assessment for clients who potentially have OCD related to gender identity as opposed to sexual orientation? For instance, can you use the sort in a modified way to assess for gender OCD, or is there something like totally separate that you would recommend?
Hmm. So there is not, to my knowledge, a specific one for gender identity. That doesn't mean it doesn't exist, and I haven't found it yet. So certainly that is a worthy question. I think that it makes sense to be able to do that, and then in terms of um, looking at, because the key component is telling the difference between the distress. And a lot of times when we do effective informed consent, one of the books that I referenced in my resources is the Clinician's Guide to Gender Affirming Care, which goes through some of the WPATH guidelines for providing gender affirming care. And then a really, really important part of that is having thorough discussions about realistic outcomes and expectations. And that gives you a really good insight into what they're hoping to get out of this. And if it's certainty, that is where we would definitely have a red flag, as well as some unrealistic expectations around feelings of relief. Because one of the things that we know is that someone's identity doesn't necessarily benefit from being hinged on it being validated by like a third party.
Right. Right. How should clinicians who don't specialize in either OCD or LGBTQ plus affirming care decide like when is it the right time to refer out versus can I work with this individual with, consultation supervision? What are your thoughts on that?
In general, I find it's really helpful, and I love that you asked this question because so often someone will have like a history of OCD in their diagnosis, and then a clinician will say, I don't know if I can work with them, but they're actually coming in for disordered eating, or they're coming in for something else, or quite often someone will be trans or have like sexuality that is non-heterosexual, and then they're coming in for depression, but they get deferred to a clinician who specializes in LGBTQ when that's not really what they're seeking treatment for. So I would say number one would be starting with asking them, like, what are your primary treatment goals? And doing what you're doing right now, where you're broadening your experience and being able to have a better understanding of the fringe of that net is super helpful,
Yeah.
because we can't be good at everything. And at the same time, the relationship and trust you have with your person is an
Mhm.
important part of that treatment process.
Yeah, there's lots of people chiming in the chat that consultation opportunity would be amazing. So, um, okay, how do I support a trans teen experiencing anxiety, depression in therapy for gender affirming care, but does not want to engage in any questions, conversations about gender identity, etc.?
Sorry, I was putting my email in the chat. Will you ask me that question one more time?
I will do it again.
I was putting for the people who want to join, for that, I'm going to put my email in there, and that will make it easier for people. They can just shoot me an email, and I will, and then let me know which consultation team, if you were like, I want to do the eating disorder for community, or I want to do OCD for community, so I get you on the right one.
Okay. How do I support a trans teen experiencing anxiety, depression in therapy for gender affirming care, but who does not want to engage in any conversations about gender identity, etc.?
Create a safe space and make sure that a part of that, when we talked about informed consent, they have to be ready. They have to trust you. They have to know that you're a safe space. Oftentimes I'll say, hey, I know that we don't get a lot of good conversation about this, and it's something that I am happy to talk about with you when you're ready. Do you want me to ask you about it from time to time, or do you want me to wait until you bring it up? And that space can be super valuable and important, because one of the most important parts of adolescence and young adults is the feeling of control and stewardship in their lives. They don't want to feel forced to do things. I don't know that any of us do. Um, the bigger idea is when I give them the space to say, hey, like, I know that this is something that was on your, intake notes, or your parent brought this up, or you mentioned this, and they say, I don't want to talk about that. Like, that tells me that there's something that I need to work on first. And sometimes they need the buy-in and treatment, so we work on what they want to work on first.
Yeah, I love that answer. I also like to, you know, that they are coming in and staying in the room and even saying I don't want to talk about any of this other stuff like that is a step towards talking. And sometimes especially with the younger population, teenagers, young adults. You spend, weeks talking about, the Knicks winning the championships for the first time in forever. And that's relationship building, which leads to talking about what they are supposed to be talking about, whatever that means.
Yes.
Um, Let me see. Oh, we have 2 minutes left. Let me just do one more question really, really quickly. Um, how do you handle cases where OCD and identity questioning like legitimately co-occur at the same time? How do you sort of navigate that and affirm all sides?
Yeah, because people, that is something that I actually enjoy that quite a bit because um, when, people are complicated, that's part of why, like, I feel sad about my alphabet soup of like treatment teams that I'm on, but at the same time, um, it's so important because we're complicated human beings, and to say like, oh, I only will treat this part of you just feels so unvalidating to me. Um, and so what I will say is that we have lots of good conversation, and we are able, like when I come back all the way to almost the beginning of my talk where I was saying the education about OCD is so important. When I'm having that conversation with them and I'm saying, hey, like let's talk about where this causes you distress and what we want, they get better at knowing that like reaction that comes in with um, OCD, and the difference between like this gives me that feel versus curiosity. And it gives us a chance to even dive into some of that emotional work about curiosity and knowing how different feelings hit us.
Thank you so much for your time and insight, Dawn. And thank you to everybody who took the time to join us today and to be a part of this really important conversation. We really hope that you're able to share these insights within your own communities as well. If you'd like to stay in touch with either of our teams, please feel free to email us at any time. Thank you for joining and have a great afternoon.